Good morning, all. As Sarah was just commenting, these monthly meetings come up pretty quickly. But it's another short format meeting. We have an hour and a half. We're going to talk about prescription drug strategies and actually put you to work to identify priorities of how we would direct the Prescription Drug Affordability Board to kind of think about some of the priorities that we see as important. So today we're going to first review those strategies that have been presented to us. And then we're just going to have a discussion on how do we identify some of the priorities that we as a committee see. And then the team will put that information together and provide that back to the state. So maybe we can make some progress on this really challenging issue. I think first and foremost, we need to take a look at the prior meeting summary. Did anyone have any comments regarding the prior meeting notes? Hearing none, we'll assume they're approved. I just wanted to talk a little bit about what we're trying to accomplish today. You know, the general public has started to recognize that not only are drug costs very high in the US, but they're growing at a rate well above CPI, and that we pay drug costs in the US that are much, much higher than other developed countries. And so as the state of Oregon, we're not going to solve this. It's going to take some federal solutions. It's going to take multi-state solutions. It's going to take some of the work that we do. So we're not going to fix it single-handedly, but we can sure drive some options and opportunities that bring us to more reasonable drug pricing. You know, if you look across other states, it's really interesting. First and foremost, at a federal level, the IRA, or the Inflation Reduction Act, included a provision for the negotiation of 10 Medicare drugs. And that seems like a fairly small number, but it's a big step. The 10 drugs that CMS has identified account for about 20% of the Medicare drug spend. So it's moving in the right direction, albeit slowly. Then if you start looking around to states throughout the union, Colorado developed a prescription drug transparency approach with some upper payment limits. So they've identified payment limits for particular drugs. Maine is established, as has Oregon, the Prescription Drug Affordability Board. Maryland also set up a PDAB and is starting to draft some upper payment limits. Massachusetts has a proposal to negotiate supplemental rebate agreements that sort of get around the price fixing component, but allow them to negotiate directly with pharmaceutical companies, and also a proposal to establish upper payment limits. Minnesota is pretty similar goal to establish upper payment limits for drugs that they've identified as being outliers and subject to review. New York did something interesting where a number of years ago, they set a separate drug cap for Medicaid with the authority to negotiate for supplemental rebates if they exceed the cap. And then to the degree that companies won't negotiate with them, they have the right to remove drugs from the formulary. Washington has a PDAB and is looking at up to 12 drugs a year where they'll try to impose some upper payment limits. Florida, as many of you know, has identified the opportunity to purchase drugs directly from Canada, which seems a way around solving the core problem of being able to negotiate pricing within the US. So you can see that everybody's kind of coming at this in different ways. And I think what it does is it gives you some idea of what some of these other states are heading towards as they discuss ways in which to get their hands around some of, or at least to mitigate some of the really high cost drug impact on members and on our state's population. So as we go forward today, we're going to remind you, Sarah's going to remind you of what our Prescription Drug Affordability Board has laid out as some options. And then what I'd really like you to do is to think about what your priorities are that we can provide to the state to help us think about ways in which we can mitigate some of these costs. So Sarah, that's all I had sort of to kick this off.
Great, thank you so much, Peter. I think why don't we skip ahead? There are some written updates in the slides and people can see those if they want about program updates, but Peter's teed us up. So let's go ahead maybe to slide 11, Gerondi. Yeah, okay, so we've shared some of this information over previous committee meetings. We've talked about pharmacy a number of times, and this is going to be just a really quick recap of some of the major drivers of what's going on with pharmacy, and then a list of some of the potential strategies that are out there to address pharmacy costs. So generally speaking, if we think about what's driving pharmacy cost growth, we can look at that in a couple of different buckets. We can look at the rising prices of drugs, and that's been really well documented by Oregon's Prescription Drug Price Transparency Program, among other sources. We can look at lack of competition and all of the factors that affect competition and negotiation. And we can look at the cost and the use of specialty drugs. This is one national organization's opinion on sort of the three major drivers. There may be other opinions on what's driving pharmacy costs, and certainly some of the strategies will approach that. But we're going to present the strategies to you today grouped around addressing prices, addressing competition, and addressing cost and use of drugs. As Peter said, this pharmacy is really complicated, and there are all kinds of levers and all kinds of strategies. And some things are really only possible at the federal level. Some things are possible at the state level. Some things will require state legislation, state legislative action. Others might not. Others might be agency level actions that could be taken through contracting or purchasing. And then there are things that payers and providers can do on more of a voluntary sort of individual system basis. And I think really similarly to how we think about the cost growth target, where it's this, everyone has a shared goal, everyone has their sort of role to play in contributing to meeting the cost growth target. I think there's no one single strategy for pharmacy. It's likely a combination and a layering of federal, state, local, and industry strategies all working in combination together. So just to throw that out there to set the stage a little bit, let's go ahead to the next slide. Okay, we're going to start with the federal strategies. We do have a document in the meeting materials that lists everything in one place. And these strategy options we've either talked about before in other meetings, and they come from a lot of trusted sources that are supporting pharmacy affordability nationally. So that includes the National Academy of State Health Policy, Kaiser Family Foundation, the Prescription Drug Price Transparency Program here in Oregon, as well as in other states, the Prescription Drug Affordability Board in Oregon and in other states. And we've, again, presented these strategies before in previous meetings back in 2022 and a little bit in our January meeting. So next slide. Okay, so I'm going to go pretty high level, pretty fast, and apologies for that, but just sort of info dumping here. So federal strategies related to increasing competition. The FDA has a biosimilar action plan around biosimilar competition. There are strategies around expediting reviews for generics to get them to market earlier. Sole source tracking, sort of on the contracting side, and sort of preferential agreements for what drugs are available when. Prohibiting pay to delay, where drugs are not brought to market because it's more profitable to not have them out there in competition. Better patent oversight, strengthening Medicare negotiation through the Inflation Reduction Act and other tools, and allowing importation of drugs. And that's one of the strategies that can happen at both a federal and a state level, as you'll see in a second.
Hey, Sarah, if you look at this list, other than strategy 1.6, they all seem to be solutions that work around the core problem that we've decided in the US that we can't negotiate drug prices, at least through government programs and or to purchase on the world market. And is there just no openness to see that, and we have to work around those core problems? Or are there strategies statewide that we as Oregon could join, maybe not lead, that would allow us to confront the core problem of, you know, there are certain drugs, and there's a whole list of them out there, but there's a particular thyroid cancer drug you can buy in France for $30,000, and in America we pay $200,000. That, I think, is part of the core problem. And a lot of these pieces could be solved if we had the ability to sit at the table and negotiate that as the largest drug purchaser in the world.
Yeah, absolutely. And again, this is a multi-layered, complicated policy area with lots of players in the stream. So this is just one set of strategies around competition, which sort of do assume that the market remains the same, that we're not looking at any of the underlying price drivers. We're not looking at anything else. This would just be about how to increase competition in that existing world. But if you go to the next slide, there are also strategies related to increasing prices, or addressing prices, not increasing prices. So these, again, are still federal strategies, although some of them are also on the state list, as you'll see in a minute. But looking at prohibiting pharmacy benefit manager spread pricing, so ways that pharmacy benefit managers essentially recoup money on both ends of the transaction. Looking at best price requirements, looking at price limits tied to inflation or other economic indicators, looking at reference pricing, again, tied to international prices, maybe like you're saying, Peter, where drugs cost something in another country and they cost a lot more in the US. Having processes for federal determinations of value of new drugs, modifying rebates, and increasing price transparency of drugs. Some of these strategies are actively in discussion federally and moving, although I did just see that the pharmacy benefit manager policies might have gotten scrapped yesterday or this morning in sort of some of the federal negotiations over the budget. But definitely these are things on the table and being talked about to directly address prices. Next slide. And then again, federal strategies around lowering cost sharing. So most of these are Medicare centric because that's where the federal government has the purchasing authority, but looking at lower out-of-pocket payment caps for Medicare, capping or eliminating co-payments for common drugs. I think the most obvious example here is the insulin copay limits. And then eliminating costs for preventative care. Some of that's already happened through the Affordable Care Act and other layers on top of that, but there's still possibly room to increase that. Okay, that's sort of the really high level federal landscape. Let's look at the state landscape. Next slide. Next slide. Quick note, you'll see this little icon on a couple of these strategies. That means that those are strategies that Oregon's Prescription Drug Affordability Board or Prescription Drug Price Transparency Program recommended in their 2023 annual reports. So last month, Ralph presented to you on those recommendations. So we just wanted to remind you which ones of these in this menu of strategies align with those recommendations. Next. Okay. So again, those three buckets, starting with increasing competition. So states could look at creating a drug label to directly contract or directly manufacture generic drugs such as insulin at a low cost. This is something California has been looking at to essentially get in the business of manufacturing directly. Again, pay for delay and preventing some of those anti-competitive practices that keep lower cost alternatives off of the market. And then changing statutory language regarding substitute requirements for biological products and biosimilars. So this would allow for broader adoption of biosimilars, and this is one of the Prescription Drug Affordability Board's recommendations. Next. Looking at addressing prices, some state level strategies include increasing drug price transparency, setting upper payment limits, and as Peter shared, a number of states are exploring that, including Oregon. Oregon's currently working on a study of upper payment limits and what it would look like to implement those.
Hey, Sarah, I'm going to interrupt you because I don't understand the state's ability to set upper payment limits and what our flexibility is on that. Is that unknown legislatively or at a federal level? Is that something we can do? Do we have anyone who has sort of deeper knowledge about what it means to set upper payment limits?
Andrew, can I tag you in on this one? I mean, my understanding is that states can do this. States can have the authority, and Oregon currently has legislation directing the state to explore what it would mean to actually set up upper payment limits and operationalize them.
That's correct. When PDAB was created, the bill that created it initially gave it the authority to set upper payment limits. That was taken out as part of the last minute deal. We're doing this study, and the potential outcome of that could be to give PDAB the ability to set upper payment limits. And I believe there is one other state, I think it's Colorado, that's currently doing that.
And I think Maryland is in the process of getting very close to doing it as well.
Thanks, Charlie.
So in the current legal structure, that is an option for states to say, we're only going to pay up to X. Is that applicable, Andrew, to Medicaid, Medicare, commercial across all state beneficiaries? What are the options there?
I'm not sure about Medicare, but the goal is to make it broadly applicable across the board. Yeah.
Okay. Very interesting. Thank you.
Okay, so states can also look at increased regulations for pharmacy benefit managers. And so that could either be transparency. So where's the money going? How are rebates are accruing and who's benefiting from those rebates, or more direct limits on what pharmacy benefit managers sort of are or are not allowed to do. States can negotiate directly with manufacturers, and this can include things like, as Peter shared at the top of the meeting, Massachusetts has that. They've negotiated additional rebates for their Medicaid program. And then regulate reporting of drug price increases. So Oregon has a drug price transparency program, and there are possible expansions to those authorities or increased reporting that could be part of that. Next slide.
Before we move on, let's bounce back a slide, please. What are our parameters on strategy 2.4, negotiating directly with manufacturers as a state? How would that work?
My understanding of this, and again, Andrew and others, please jump in and correct me, but my understanding is that this is a strategy that tends to focus most on Medicaid or potentially on public employees where the state is also the purchaser. I think in the case where a state is doing, consolidated purchasing and has the opportunity to come together under some sort of purchasing consortium, which Oregon has and is part of, that there are potentially opportunities to negotiate more broadly on behalf of multiple payers in that consortium approach. But I think sort of at its core, this starts with Medicaid and then expands out.
That's correct. Yeah.
So I have a quick question on two of the pieces here. So you said these would apply where the state is the purchaser. Could you expand on that a little bit more? And then I have a question on 2.5.
Yeah, so the state generally is considered the purchaser for Medicaid. State is the payer, the one setting the benefits, managing the contracts, as well as doing that for public plans. So those are commercially insured folks. state employees and Oregon educators. The state is the purchaser, managing the contracts and setting the requirements and parameters for those covered lives. Also, as states, and Oregon is in this position, move to the state-based marketplace for the Oregon insurance marketplace, folks that they're purchasing on the individual market, the state will have some ability in the future to sort of have more control over the purchasing components. So sort of setting requirements. Right now, Oregon's a federally based marketplace state, and we don't have sort of as many options, but in the future, under a state-based marketplace, there's possibly some additional purchasing authorities that could be utilized. Jessica, did that help?
Yeah, thank you. I've anticipated the PEB and SEB and the Medicaid. I was curious about marketplace, so thank you. And then on 2.5, can we talk a little bit more? I'm trying to balance this just to what was in the courts recently and what was overturned. So I was wondering if we could talk a little bit about that, just to make sure I'm keeping up to date on everything that's happening there. So I was wondering if you guys could comment on 2.5.
Andrew, sorry.
Yeah, so excuse me, I'll have to be a little careful here. There is a bulletin that we put out that maybe I could link to in the chat that gives a little background, but Pharma has challenged a portion of the state's drug price transparency program. We had a summary judgment order in the case where the state prevailed on several grounds and Pharma prevailed on some grounds. As a result of that judgment, we have suspended a portion of the drug price transparency reports and information that drug manufacturers have to file with us on some of the detail that we provided. As we say in this memo, we think the judgment was entered in error, and we are working with DOJ to appeal that. I'll say I personally feel pretty good about the likelihoods of success, but that'll be a lengthy process to go through on appeal. We don't even have the written opinion yet. So this has been an interesting process with the court in how the decisions have been announced and structured. We've got a judgment order, which is just very high level court, on the different counts. The written opinion, which actually describes it, we're waiting on that. We do have there was a hearing in which the judge gave his kind of talked about the theory of the case, and sorry, I'm getting a little to the weeds here. We're waiting for that. We will appeal, and there'll be a lot more to come, but it's kind of a very narrow ground, only part of the program.
And Andrew, I don't want to get you in trouble, but is it fair to say that this applies to a very narrow part specifically of what the manufacturers report? So all of the reporting that's coming from insurers, all of that sort of remains intact and could be expanded on potentially in the future.
That's true. And manufacturers still have to give a fair amount of other information. It's just kind of like basically narrative explanation as to the reasons why. So there's one section in the law which requires 10 or 12 like specific questions to be answered, and that's what's been suspended.
Okay, Girardi, let's go to the next slide. I'm going to share the last set of state level strategies. So again, these are focusing on lowering cost sharing, so more direct effect to consumers. So limiting consumer costs on medication. So again, this would be like the insulin copay limits. Require more reporting on copay accumulators. And there is a bill on this moving through short session right now. I believe it's being heard tomorrow in Senate Healthcare. Support distribution of lower cost generic drugs and expand reporting requirements on patient assistance programs. So there are a number of patient assistance programs that drug manufacturers offer. They often will cite that as a reason for drug prices aren't that bad. Look at all these assistance programs, but the data is a little opaque there as well. So again, menu of strategies, not any single one of these strategies is a silver bullet or the only single solution. It's likely that a combination of these are really truly needed for a holistic approach. So I'm going to stop there, Peter, and I think kick it back to you, see if there's other discussion or other questions about any of these strategies.
Yeah, you know, it's a little hard to kind of piece all these things together. There's an awful lot of information, but as you think about the big buckets of strategies, either federal, state, or lowering cost sharing, let's start with, is there anything that we particularly missed or that you'd like to see on that list before we consider? And I think part of our goal, Sarah, if I'm correct, we're responding back to the legislature. Is that correct?
I think what we want to do is put together recommendations that the committee will make to the Oregon Health Policy Board at the end of the, now through the end of the year, to address healthcare cost growth and affordability more broadly. And so it's possible that we have one or more recommendations related to pharmacy that feed into that. The policy board may then pass some of those recommendations on if they are legislative recommendations, but also recognizing that not all recommendations necessarily lead to legislative action or need legislative action.
Great. Thank you. So let's start with what's missing. What didn't we pick up? Michael?
Yeah, hi all. I'm sorry if I missed this when we started. I was late to the meeting, but I'm trying to come back to the equity framework that we came up with last year. And I certainly don't know enough about the supply chain and how this all plays out to know this, but how do we know if there are any downstream negative impacts to our priority populations that we're trying to, like, do we know, like, in some of these things, when it eventually gets down, it passes on and increases pay or cost to the consumer? Or has that analysis been done on all these strategies to see if it's either positive, negative, or neutral?
Michael, thank you so much for flagging that. We should have talked about the process. So I think what we've been thinking as staff is that today, possibly the conversation, you all will maybe shortlist a few things, and then we would want to do that equity impact analysis on those strategies and those policies and bring that back before the recommendation is finalized. So no, we have not gone through this entire list and done that, but we would want to for anything that was being shortlisted or sort of seriously considered. And Andrew, again, putting you on the spot, I don't think that it was part of the PDAB or the Prescription Drug Price Transparency Program. I don't think they did any equity impact analysis on their recommendations for the 2023 report either.
Not yet, no.
Thanks, Michael. You know, I think it, to a certain degree, some of that work lives in that last bucket of lowering cost sharing. And identifying where that cost sharing is. I also think that the transparency around manufacturer assistance programs and how we get that information to folks so that it's not just coming through select areas, whether it's providers or direct mail or through pharmacies, but that it's available across the board are maybe, baby steps towards some of that. Other items that we missed, Jessica?
Yeah, I don't know that we missed it, but one thing that jumped out at me is some of this isn't actually lowering the cost, but some of it's cost shifting. So I want to make sure we're transparent that we might move some stuff from where consumers might pay at the point of sale versus where they might pay, in premium, right? If we're moving stuff. And then you just talked about accumulator policies and coupons and all of that. I think we want to be really clear about how we handle those and what our recommendation is there, because depending on how we do it, and if we do it well, we can reduce overall costs, but if we don't do it well, we could actually make it more expensive for consumers. So I want to make sure we spend some time there on the nuances on how we bring a recommendation forward, but like the robustness of what was put together here.
Yeah, thank you. Teresa?
Yeah, one of the areas that I'm, excuse me, wondering about is is pharmacy waste. And there's, I don't know why I can't get it out. There's not only overprescribing, but then medication, medications that interfere with others that members are taking. And I think it is listed as something on one of the agency recommendations. So I'm glad to see it there, but just wanted to call out the whole category of waste and really things that can be done to prevent from overprescribing or using meds that, or paying for meds that end up not being used. So.
Greg?
Yeah, I think some of this continues from some of what Teresa was just saying. One thing I'm interested in is possibilities related to limiting prescription drug advertisement direct to consumers. I think that intersects with issues of overprescribing, issues of name brand products being prescribed over lower cost generics. And then of course, like I assume a tremendous amount of money that pharmaceutical companies are spending on advertisements are flowing into the costs of the medications themselves too. So I don't know what abilities we have at the state level to attempt to address that side of the issue, but I'd be interested to learn more about that.
It's a really interesting question, Greg. Charlie?
Thanks.
Yeah, thanks for saying that, Greg, because that made me think of another thing that isn't on here that may or may not be incredibly promising, but I don't remember what session it was, but relatively recently, the legislature passed registration for pharmaceutical representatives, basically marketing directly to providers. And so I imagine PDAB is probably looking at this as well, but just, follow up on how well that worked. Is there more that we can do to kind of go beyond just licensing, but actually, do something to address how that impacts prices?
Other thoughts? Other things that are notable standouts that we're missing? I want to go back to Jessica's comment for a minute, because it's, I think, a really important one. And it dovetails with Michael's thoughts, which is cost sharing or cost shifting, depending upon supporting the member, does not solve our core problem of cost growth target. Because if the costs haven't left the system, and we've moved them around, we may have solved the equity piece or moving towards solving an equity piece, which is really critical, but we also have to get the costs out of the system. I think one of the things that Sarah and Remy and I talked about a little bit a couple weeks ago was really around the fact that we have cost trends in external third parties like pharmacies that are well in excess of the cost trends of our providers within the state. If we can't figure out a way to manage those external costs, the cost growth target work that we're doing is going to put undue pressure on those folks that live within the state and are therefore under the pressure of the cost growth targets in a different way. And so there's almost a point in time where we have to think about what are the pharmacy and external cost trends outside of the state, and how do we bring those down over time to the 3.4% so that we're not leveraging off of those folks who are on this call that we know that we can call up and say, hey, I need better cost trends from you, because we can't control the fact that we're running a 6 to 7% pharmacy cost. And I think that gets really critical. And so as we think about lowering cost sharing, it's an absolutely essential component of it, but we also have to lower the underlying costs, or as Jessica says, it shows up in premium if that cost remains.
Would it be fair to say that in these comments, I'm sort of hearing interest in addressing the underlying problem, and that would be the strategies that are about prices. And that's where maybe some of the primary interest is, with some caveats and cautions about how those are implemented, or who, avoiding negative effects of any of those policies, but that the interest maybe is more on prices. I'm seeing some heads nod.
I think I said this in the chat. I mean, I feel like they go in hand, but competition too. Not like if we're just kind of looking at the different, slides here, the increased competition ideally would have an impact on prices as well. So I would recommend.
Charlie, how would we go about increasing competition from the state standpoint? What are your thoughts there? Is there a recommendation that we could sort of formulate? I absolutely agree with the concept. I'm not sure I fully understand how we as a state go about that process, and maybe Ralph and Andrew and others have thought more deeply about it than I have.
Well, I think I'm just pointing to the strategies 1.1 and 1.2, kind of maybe expanding the ability of the state to, well, I know California is kind of creating their own insulin manufacturing program. I don't know exactly how it works, but it seems like, something if Oregon could work with them, buy into that. And then there have been several legislative efforts to address pay for delay at the state level. They've run into a variety of roadblocks, but I think it's not something that we should give up on. So I think just the two that are in here are things that I wouldn't want to leave behind in terms of prioritization.
Sarah, do you want to start a list for us, or maybe Remy, if you want to start kind of identifying some things, so as we get towards the end, we can put them in an order. But I think competition, and specifically around, do we want to go into the manufacturing business, or do we want to negotiate with the existing manufacturers, I think is a critical component of how we direct the policy board. The other, and I think it's a really interesting place to go, is to talk about the pay to delay, or some other mechanism to get available drugs onto the market when they're created.
And can I also, on the state level strategies to increase competition, the PDAB is recommending increasing biosimilars competition for biosimilars. So that recommendation is out there.
So does the committee have a sense around, I like both of those pieces, the biosimilars, the pay to delay. I'm really interested in folks' thoughts about whether we should participate with a multi-state consortium around manufacturing, or whether that can be best done. I like your pay to speed up, Lawrence. Thank you. Or whether that's a quicker path to that is negotiation, and I don't have enough deep knowledge to know which one is got more promise.
I don't have deep knowledge on it either, but I can work within our organization and industry experts to help with that. But I don't have enough experience on that one either. Sorry.
Yeah, I think my recommendation was more, these seem like promising potential things that we should at least learn more about and decide whether it makes sense for Oregon.
That's great. So increased competition is one of those, and under that, there are a couple buckets, I think, Remy. Where else would you go? Given the magic wand today, you know, we're in a very fortunate situation. We don't have to solve anything. We can just say, do this. So if you could say, do that, you know, regardless of really the legal path to getting it successful, what would you do?
Well, I was curious how Florida is purchasing from Canada. I mean, is that something that would be open to Oregon?
Where does that stand currently? Do we know where that is? I imagine it's tied up in appeals at this point.
Somewhat facetiously, I thought that Canada was like, actually, no, we don't have enough drugs to send any to you.
There is
I
that.
thought that was where that was currently landed, but
But I mean, from the US standpoint, is that an approved, I believe Florida passed that law. Is that currently approved or is it tied up? I appreciate that maybe Canada doesn't want to send us all their drugs.
I don't know off the top of my head.
Okay.
We can definitely look into that and
What-
share back. Does
I think it's worth, because I think what it does is set a federal precedent. I don't think Canada is a required option. It sort of opens up that if you can't negotiate to world prices, can you buy world prices in some other mechanism? And I don't have any knowledge about the legality of that approach, Gil.
So making the reference pricing, you know, more explicit, you know, at least that would be one step, you know, for us to see what that is.
So is there general interest in, Jim? Why don't you go ahead? Can't hear you, Jim. How about now? Oh, you're double muted, Jim. Why don't you put your question in the chat if you want, or your comment? And if you figure out where the other mute is, I would help you, but I am completely useless around IT issues. Michael?
Yeah, I'm putting on my community engagement hat. This is gonna sound like a really simple suggestion for a state strategy, but in terms of something that's missing, what if the state had a more consumer focused campaign to try to destigmatize generic drugs? I think there are a lot of people who think that they're not as effective. And it was like something like the call to action was like, ask about a generic. And so there's kind of a consumer focused effort in our state, and it's really simple, I know, in some ways, but maybe that would help as well.
You know, it might be really interesting to better understand as one of the opportunities to better understand what the extent of generics are. How much could we move from brand to generic? And then what would that process be, Michael? That'd be really interesting. It may be an easy way to pick up some dollars. The price trends on generics are very different than on branded and on specialty drugs. Charlie?
I mean, I think if I were to kind of pick the thing that seems like it has at least the most potential promise to address the underlying cost, it would be upper payment limits. Admittedly, there isn't a whole lot of, I mean, you know, there are a couple states that are in the early stages of actually implementing them, so it's a little bit speculative what the impact will be, but just kind of theoretically, it seems like that has the potential to have the widest application and impact, and obviously is really directed squarely at the prices. So, you know, if I could wave my magic wand and kind of, you know, potentially put aside the legal issues and, you know, implementation, which, you know, who knows, I think those can be addressed, I would put that at the top of my list.
Can I, if I'm remembering back to Ralph's presentation last month, the development around upper payment limits, is that for a set number of drugs? It would be upper payment limits for 10 drugs or so. It's not sort of upper payment limits for all drugs in the commercial market. It would be like the top most expensive. Andrew, you're nodding, is that right?
Yeah, other states have done it, tied it to the 10 most unaffordable drugs. And that's, so PDAB is going through that process right now and is a few months away from finalizing a list of the 10 most unaffordable drugs. And that's what the upper payment limit could be tied to.
And Andrew, I don't know if you can see Lawrence's question, but he was just asking for some more specificity about how that works. Is that upper limit the total cost? Is it an upper limit of what patients can pay and the rest gets passed through the system? Lawrence, other thoughts on that?
Yeah, it would help me just to keep my mind straight. If someone could walk through kind of how it would work and how it would impact all the potential players in the system, the patient or member, the citizen, the resident of Oregon, providers, pharmacies, plans versus pharma.
I think those are great questions, and there's a lot of flexibility on how a state could design this. What I might suggest is to have someone or some people come and talk, and it would also probably be more than a couple-minute conversation. We can kind of come back and talk through like a lot of the details about what that is.
Totally agree. That's a complicated question. I think my understanding at a high level is that it's the payment limit applies to how much the payer can pay, right? It's capping the amount that the payer can pay for the drug total. That's the level it's set at, not the consumer out-of-pocket level.
Yeah, I think conceptually it's basically the maximum price that can be paid for a particular drug by anyone in the state.
And
And
so
is
the
it both-
drug cup, I'm sorry.
I was just going to add on it. So, and we're talking about prescription drugs, so stuff that falls through the pharmacy benefits versus other specialty drugs that go through medical benefits that like administered at a clinic or a hospital. We're sticking to we're focused on it's on the prescription side or retail.
We're getting past my ability to.
Okay.
I don't know that it has to be, but I'm not confident of that answer.
I think it's really important as we make recommendations on the upper payment limit to recognize that there are different places of service. And those places of service are going to continue to change rather dramatically. You know, your Ozempic, it may come through your weight loss clinic as opposed to your physician and or your hospital in the future. So as we think about upper payment limits, we may want to think about sort of agnostic towards site of service. And that would allow us to identify those drugs that are really impacting the system most. As I think Melissa or either Jessica pointed out at our last meeting, you know, a lot of the super high cost stuff is actually running through the hospital medical bills and doesn't show up in the payer's expenses as a pharmacy cost per se, because we reimburse the facility for it. Two
quick comments. One, the cost growth program is working with a small group of payers right now to do a pilot on measuring that medical pharmacy spend to figure out if we can wrap our head around that and if we can capture that in our cost growth target data. So we'll know more in a couple of months about how viable that approach is and if that's going to be data we'll have on a regular basis moving forward. So working on trying to capture that and identify it more directly. Two, I'm hearing that there are a couple of these policies that would really benefit, or these strategies that would really benefit from a more in-depth discussion. And maybe that is something we want to move to our March agenda, we could invite Ralph and some of the other DCBS staff back to talk more about the upper payment limit study and where that work is. Does that sound right? Does that sound like the direction we want to go for the March agenda?
Yes, Sarah, I think, it was funny because many of our organizations have really experienced pharmacists and pharmacy folks that deal with pharmacy every day. Those of us on the call are not those people necessarily. And so I don't know what the forum would be to take these very generic recommendations and to really break them down into realistic options, whether it's through our committee or through maybe using some of the skill set of the prescription drug board. Lawrence, you had your hand up.
Now, I would just like to yes, I think it'd be great to have a much more in-depth conversation about this. Both noting two things. One, Peter's differentiation between a cost shift and a cost reduction. And then expanding that to note that, everyone's price is someone else's revenue rate, right? And that revenue covers everyone else's cost and either their profit or their loss, their gain or their loss, right? And if we're thinking about actually sustaining a sustainable growth rate of costs within Oregon, we're saying that pharma's costs and profit are outside of that wall, right? And it's one thing to shift through either competition or price negotiation to lower, hopefully their profit a bit, to reduce costs within Oregon. It's another thing if we're shifting just the cost elements within the Oregon system, whether it's being health plan and provider or patient and plan benefit, et cetera. And so understanding the upper payment limit in that context would be very important from my perspective.
I think that's a good note. Jim, I'm going to bounce back to you and see if you've fixed your mic.
Okay, I've tried a different mic. Does this work? Ah,
You're on.
thanks, Remy. Okay, so both considering the legal constraints that the U.S. economy puts on public efforts versus private profits, and considering our the fact that Oregon is small compared with the size of pharmaceutical companies and their political power, their economic power, and considering that there have been other opportunities to partner with British Columbia, with state of Washington, with California on, for example, environmental solutions to problems. And because Peter said, well, what are some ideas? I thought of a partnership between California, Washington, Oregon, and British Columbia for both acquiring and manufacturing and making available pharmaceuticals, and whether that, one, it seems that would enhance British Columbia's economy if they were providing that resource to the West Coast states of the United States, and could possibly enable us to, just the word, bypass or solve some of the regulatory constitutional problems that the pharmaceutical companies might throw up in our path. So that was my idea.
I think, Jim, it's really interesting to me to note that each state is, well, they're dealing with the same issues, they're dealing with them separately. And Andrew, I don't know what the discussions have been more broadly But certainly, state of Oregon with 4 million population versus some of the larger states is not going to have the ultimate clout, even from a negotiation standpoint or an upper payment limit standpoint, that a much broader population of the US would have. What have those discussions been, or have there been discussions on a collaboration that might even include some other countries?
So there definitely have been discussions and collaborations, especially Oregon, California, Washington, on different purchasing collaboratives and things along those lines. Might need to phone a friend and bring in someone who's been more involved in those discussions than I have, though, to really dig into the details of them. But I absolutely know that there have been those discussions.
Thank you. Jim, I think it's a real necessity, and whether it complicates or streamlines the political issues that are realities that we're dealing with, that's way above my pay grade.
But it gives us some leverage, gotta admit.
Peter, can I jump in here?
Please.
I think on one hand, when we talk about pharmacy, it makes so much sense to be thinking about this at the state level, the federal level, the national, the international, right? Because it is so complicated and this can feel so much bigger. But I also wonder if there are additional conversations or strategies that are almost the sort of payer and provider sort of more voluntary. They're not necessarily state legislative mandates or changes, but they're things that payers and providers are doing and have been doing to try to address pharmacy costs. And if any of those are worth some additional discussion, or from a spreading best practices, thinking about the way that this group has identified voluntary strategies previously, and if there's any discussion that's worth having again at that payer and provider activity level.
What do you all think about that?
Well, I was curious if that was an area where the role of the PBMs, and how they what the costs are there that seem very opaque, and how to make those more transparent, and maybe there's some opportunities there, for some cost reductions.
It's really interesting. I think it goes back to some of the transparency spread pricing discussion that Sarah just had around, I think we all, whether we're on the provider side or the payer side, we work every day to minimize the prices and the price increases, because it's very, very difficult to continue to raise premium prices to support the cost trends in pharmacy. So we're doing that every day. I think the real question for me is, are there things that the state could do to help in that process, especially, Gil, as it relates to PBMs? And I'm not sure I know what that would be, but I think that's maybe a worthwhile question to put on this short list that we're then going to try to prioritize a little bit. Other thoughts about that? I know that gets to the heart of what a lot of us do. And so it's a little more personal, but I think it's an important component. Sarah, would you just recap for us what maybe some of the PBM components that are either federal or state that we may have the opportunity to benefit from?
Yeah, so there are the recommendations around increasing transparency. So what what's happening through the PBMs, where is the money going, follow the money, all of that sort of transparency reporting. And those recommendations would be essentially an add-on to the state's drug price transparency program, I think is where most of that has landed so far. And then there are the restrictions and prohibitions on spread pricing. So essentially saying that PBMs can't turn around and mark something up or can't charge more or be recouping more than they're charging for. Sorry, I'm butchering that as a simple explanation. We can do a more in-depth overview of spread pricing if people would like in March, but broadly speaking, it's trying to mitigate that sort of profiteering in the middle.
For those of you that haven't dealt with PBMs, they are opaque at best. So should we move to the next phase, Sarah, or are there?
Yeah, let me summarize what I think I've heard and where we are for March. Does that sound right? Okay, so I think.
Yeah, do that. I have a list. I want to make sure we hit that list, and then I'd really like the group to do the hard work of saying these few things should be at the top of the list.
Okay, so I heard strong interest in addressing both price and competition. Interest in making sure that anything that we're looking at the effects sort of throughout the system, whether that's with an equity impact assessment or sort of understanding how it would play out with the payer, the provider, industry, and the patient perspectives. A lot of interest and questions about upper payment limits, needing to come back to that in March and hear from the PDAB on where they are on that and some of the operational questions. And sort of side note, I think we're in a tricky space. And I just want to recognize that, where we're not trying to duplicate the work that the PDAB is doing. We're looking to see how we can use the cost growth advisory committee's position and opportunity to make recommendations to support that and to strengthen that. And they're in the weeds on some of these details, and that's okay. We don't necessarily need to be, but how do we keep that aligned and how do we get those questions answered? Couple of questions, comments, and interest in strategies related to negotiation, whether that's importation, international reference pricing, or some sort of multi-state or international purchasing consortium. I think we could come back and share more in March about the existing purchasing consortium that we have in Oregon and the work and where all of that is, and understand if there are opportunities to build on that. And then I think there's some interest I heard interest in increased transparency, particularly on the PBM side. And then finally, some strategies, as Michael was suggesting, maybe that are addressing more of a consumer-facing campaign. So promoting generics, do biosimilars work? Where are there opportunities to either address waste or opportunities to have a preferred, sorry, I'm trying to say this right, preferred prescribing, or in ways that are more affordable to both the patient and to the system. Lawrence?
Thanks. I thought that was a great list. Just on the last one, which I am very much in favor of. If we could just add to your list, how can we have pharmacists practice more at the top of their license to be part of the solution to this as well? Because I think there's some real expertise that we need to draw into this as well.
So if I take those pieces, Sarah, I almost break them down into 4, maybe 5 buckets. One is increased competition. And then there's sub bullet points below that, like the biosimilars, like manufacturing, et cetera. Like the, pay to delay or pay to speed up or whatever that was. And then their payment limits, which includes the upper payment limit bullet point, but maybe also international reference pricing as a component. Then there's the focus on cost reduction necessarily versus not, maybe not versus, but just be aware of cost reduction versus cost shifting from the cost growth target. Then I heard collaboration with other states as a solution to really building the potential to get something done. And then I heard about a role of the PBM, and under that increased transparency, restrictions on spread pricing, et cetera, et cetera. And then there's this other component that we've raised in a couple of places, which are, what are the easy steps that we could do within the state, within our various organizations? One is pharmacists working at the top of their license. Others are the discussion around, can we highlight generics? Can we deal with some of the advertising issues, et cetera? And so those are kind of the big buckets: increasing competition, limiting payments, collaboration and PBM, and then stuff that we get done here. I think you have to screen any solutions through the equity component, and we need to make that really explicit as we make recommendations. But I think you have these recommendations around cost. They're all subject to making sure that we haven't exacerbated equity issues within the state. And then I don't know how we would go about whether that list is maybe a list, or whether we would go about organizing that list.
Peter, can I ask the group off of that list and that framing, in addition to the upper payment limits, is there one of those other topic areas that people are most interested in or have the most questions about for March, so that we can bring that information back or shape that agenda a little bit?
If you guys get to hear more specificity about any of these line items, which ones do you pick?
Would you mind dropping the categories into the chat? I don't know, Sarah, if you handwrote them or typed them.
I just
That'd
love
be
that
really
you think that I
helpful,
was
Jessica.
typing live.
I was typing. I can do that really quickly.
And I
Sorry
think
for the dictation requirement there, Remy.
and I think, can we also pause and make sure that we're hearing from everybody? I know we've got committee members that we haven't heard from yet today. So if anyone else wants to share thoughts, make sure we make some space for that.
Hard to choose. But I don't know. The idea of trying to collaborate with California in their generic drug manufacturing sounds like a potentially promising strategy that I would love to learn more about. So if I had to choose one of these additional ones, I think I would do that one. But you know, I don't feel strongly enough to say that I wouldn't be interested in some of the other ones. So curious what others think.
So if you think about the big category, that's really under collaboration with
Yeah,
other
yeah.
states, as Charlie's recommendation. Other recommendations for some of the items that we want to move forward, or do we want to move sort of all 5 forward?
The one that I think we could impact most quickly is the cost reduction versus cost shifting. I'd be interested in moving all 5 forward, but if I had to pick one, I'd probably focus on that piece of it. And Peter, when you and Lawrence were talking, you made me realize, I don't know if it's in scope for this committee, but do we also add in things like care management or population health or how we address social determinants of health, it might be a step too removed, right? Like if you can help people adopt a healthy lifestyle, maybe they don't need their diabetes drugs or they don't go down that path as quickly. Is that too far out of scope? So I go from the like, we don't address it till folks get sick and balancing it with what can you do to help them not get sick?
Yeah, it's really interesting, and it probably fits in my mind, that last bullet point about what things can we affect without the sort of legal structure of changing how we interact with pharmacies. Some were the pharmacist stuff, some are the more generics, maybe advertising. I think it absolutely fits in that bucket of population health management, which is something that we can do for you know, not only the Medicaid population, which is paid for through OHA, but a broader group of populations. Karis, you had a comment.
Oh, I was agreeing with those two recommendations, the collaboration with other states, and then the second one was the cost reduction versus cost shifting in the system. Those were the two. I like all five, but those were the two that I would push forward.
Okay. Other comments?
Peter, I'd like to make an ask of the committee members. I think this is incredibly helpful for us as staff in thinking about how to prepare for the March agenda. But can I ask committee members, please feel free to talk internally with any of your pharmacy folks if you have them. I'd love to know what your specific questions are. You're saying more information, like more information about what? Like, I want your list of questions. Like, what does this mean? How would this be implemented? Like, any and all questions that you have about these topics will help us shape the agenda. So please feel free to send us an email in the next couple of days with what your questions are about some of these strategies, and that will be really helpful for preparing for March.
Yeah, that'd be great. Teresa, you had a comment about payment limits.
Yeah, that would be, you know, I think we were talking earlier and not quite understanding how that would work. And so more information on how that would work would be great. You know, where is it the payer? Is it the total cost? Is it, how does it affect the different players in the whole system?
Okay.
Thanks for your comment, Nick. You know, in regard to your comment, Nick, I don't have enough clarity about where the profitability lies across those various areas. I would maybe say yes to all of that. So Sarah, what I hear you asking is, would you talk to folks within your organization? Maybe what we could do is get a really clean list, and I can work with you and Remy to get a really clean list of, these are the 5 areas we've identified subject to equity screen. And I just want to keep emphasizing that piece. And what would you specifically like to understand about the state's ability or current discussions about either legislation or collaboration around each of those issues?
Yeah, I think we can commit to getting that summarized, sort of one page of what we talked about out. And then I think we wanted to do this for this meeting, and it ended up being a little bit too much content, but I think we can promise it for the shorter list of content for March. We can do a little bit more to summarize, like, what does this strategy actually mean? Has there been previous state efforts on this before? Like, what are we saying the recommendation actually is here? So we can work on that for March as well. Okay.
And sorry, what's the timeline for this recommendation? Is it just like ahead of the next legislative session? So end of calendar year, or okay, cool.
Yeah, Charlie, at this moment in our draft calendar, we are slated to go talk to the Oregon Health Policy Board in December about this type of recommendation.
Got it. Thanks.
And again, some of this is overlapping where the PDAB study on upper payment limits, I believe, is due in September. So that information will be out certainly before long session.
Great.
Okay.
Well, I really appreciate everybody's participation. Take advantage of following up. We all gripe about this particular issue, and we actually have an opportunity to highlight some things that we think might be solutions. So please take that opportunity. Sarah, where do we go from here?
I think we'll reiterate, please send us questions. We'll summarize. And we will get that summary out to you in the next couple of days so that you can have those internal conversations. I think I just wanted to plug a couple of housekeeping things for the program, if this is an okay time to do that. We held our first educational webinar. We discussed this as part of our series for the year, that we'd have these educational webinar opportunities to go more in depth into reports or data or other programs that are related to affordability and cost growth. So yesterday we held the first of those webinars on hospital community benefit. That webinar was recorded and will be posted online along with the materials for folks that are interested and weren't able to join live. We are planning on doing our second educational webinar in March. The date is not on the calendar yet, but we will let you know as soon as we pin that down. And the March topic is going to be a deep dive on an analysis of patient cost sharing that the team's been working on. So we've been looking at copays, coinsurance, and deductibles and how that plays out across markets and service categories. And we want to share that data. So we'll keep you posted on that scheduling. And then final update is we do have one vacancy and we'll be talking to the policy board to appoint a new member next week at their March meeting. So hopefully we'll have our final seat filled real soon. I think that's all for housekeeping. Any questions or comments about that?
Sarah, in preparation of May, when a number of people's terms come up, what's the process for you to touch base with folks, et cetera? That's a bigger housekeeping one in my mind.
No, thank you so much for bringing that up. Remy and I have both been sick, and so we're a little behind schedule, but we are going to start reaching out to folks individually to check in about interest in continuing for another term or not. And once we sort of have that check-in with you all, we will open recruitment for the vacancies that we anticipate. So I'd say starting maybe next week. What do you think, Remy? Next week, we'll start those reaching out for those individual conversations with people.
That sounds about right. I would say we're probably going to separate out the emails of like following up this conversation with all the information that we just shared. And then we'll start bugging you to get onto your schedule so we can talk to you about just like your future with the committee and how much you're enjoying it and how much you would love to continue working with us. I'm expecting that's going to be most of our conversations at least.
All right, and then last housekeeping, Peter, it looks like we do not have any written public comment, and I have not heard that anyone wants to submit verbal public comment, but we should pause and
We should pause and ask, is there any public comment? Hearing none, I think we can move on. We ready to adjourn?
I think
Early?
so.
Mind you. We'll give you 10 minutes back. Thank you for your time today. I really appreciate it. Please do follow up and also start thinking about, if your term's coming up, why you want to continue to participate with enthusiasm and energy. Thank you.
Thanks, everyone.
See you next month.